Good morning, everyone. And the committee will come to order. And I want to welcome our witnesses. I also want to ask unanimous consent that Representative McMorris Rogers and Newhouse and Scheer be able to participate in today's questioning. Hearing no objections, we'll proceed. The Cerner EHR went live in Spokane, Washington nearly 3 years ago. It then went live in Walla Walla, Columbus, Roseburg, about 2.5 years ago. But things still aren't right with these medical centers and their clinics. When I went to Walla Walla and Columbus last year, there were still struggles to get back to normal. The number of appointments was cut back, the employees were furious, and the veterans were confused. I understand these facilities have managed to get close to normal patient volumes by adding a whole lot more staff. That's more people to do the same amount of work. But we still can't trust Oracle, Cerner, EHR to be safe, accurate, so VA employees are being forced to double-check everything. And those extra employees cost us a lot of money. The staff costs, reduced collections, and higher community care costs have put some of the medical centers in permanent budget deficits. This is outrageous and a terrible situation. I don't know how anyone with a share of the judgment could call EHR a success. But a parade of VA and Cerner executives repeatedly tried to tell us how great it was, over and over and over again. And it just wasn't. And we kept seeing it. And I want to tell you that the problems that came to us didn't just come to one side of the aisle. Both Republicans and Democrats have agreed. We see this problem, and we have tried desperately to get it fixed. But the problem became overwhelming when the Secretary McDonald finally did the right thing in April and declared an indefinite pause. This is a pause I had been calling for since 2021 because our staffs, as I said, on both sides of the aisle, had been watching and seeing things go south. Now the VA is in a reset where Dr. Evans has to figure out how to fix up a broken system. Dr. Evans, I don't envy your task at all. Your punch list has got to be a mile long. But not only does the EHR have a lot of built-in problems, VA created new problems in trying to customize it as well. VA leaders are going to have to make hard decisions they've been avoiding, and veterans care depends on it. Unfortunately, the previous directors of the project wasted far too much money. They spent over 50% of the budget and only completed about 3% of the rollout. This is a deep hole to climb out of. If you were able to pull it off, we are going to see the improvement in these medical centers. I'm not going to accept anything less. Under no circumstances should VA deploy the Oracle Cerner EHR elsewhere until these facilities have made and are made whole. Now that's the test. And Congress has been letting VA grade its own test for too long. We were far too hands-off at the beginning of this project, and when setting our goals and when they really mattered, we kept our hands off, but we're not keeping our hands off anymore. We need to establish a clear and what our expectations are so that everyone knows and understands where we want to go. I want to thank the ranking member Takano for working with me over the last few months to refine the EHR reset legislation. And I also want to thank Senator Tesler and Senator Moran for collaborating with us. Now our staffs are going to be working together to hammer out an agreement. It's simple. The project has to deliver results or end. We cannot allow it to stumble along and spend more money and more time and not get the results we need. We're going to find a solution that gives veterans the level of service they have earned and does right by the VA staff. Now, that's my commitment. Ranking Member Takano, I now recognize you for your opening statement.
Well, thank you, Mr. Chairman, and thank you to the witnesses for being here today to discuss this critical project at the Department of Veterans Affairs. I want to start off by welcoming Dr. Evans. This is the first time that we've had you before our committee and before the full committee since you assumed leadership of the EHRM program. So welcome, Dr. Evans. The program needs strong and stable leadership, and I'm optimistic that you are the person for the job. And I'm optimistic as well that we're going to be working together with you to ensure that the EHRM gets back on track. Like most committee members, I was supportive of VA's announcement of a reset of the EHRM program and the decision to delay any further go-lives while VA and Oracle fix the issues at the 5 sites currently live on the Cerner system. I am concerned, though, to hear that VA is moving forward with the program at the Lovell Federal Health Care Center. While I understand that DoD needs to go live at the Lovell facility to complete its program, I think it's risky to deploy a system that has been so problematic at a facility that is very different from any other facility in VA or DoD. We cannot allow DoD to pressure VA into going live prematurely, just so that DoD can reach its goals. This program cannot afford another failed go-live. I'm glad to see witnesses from most of the live sites today. I'm hoping to hear about their perceptions about progress with the system. The frontline staff at these facilities have borne the brunt of the struggles with this program. We owe it to them to ensure that their feedback is being taken into consideration at this reset, as this reset moves forward. VA has a major task ahead of it to change the hearts and minds of staff about the benefits and potential success of the program. I hope that the program office is taking its obligations to the frontline staff seriously. I'm also very concerned that it appears that VA is too busy treating the symptoms of this program to think strategically about preventing these issues from resurfacing at the next facilities to go live. I share Ranking Member Sheriff McCormick's belief that VA must focus on developing a baseline EHR that minimizes deviations as the program moves forward. I also believe that VA needs a robust governance structure to ensure that any changes made to the baseline are absolutely necessary and are in the best interest of veterans. Constant change requests have and will continue to have major impacts on the cost and timeline of the project and will force staff at the active sites to continually adjust their workflows. Because of this, and my concerns about the future of the program, I'm pleased that Chairman Boss and I have been working together to draft the House's version of the EHR Reset Act, building on the great work from Chairman Tester in the Senate. We have spent a considerable amount of time discussing the struggles with the program, and now we need legislative action to force some of the structural and accountability measures that are necessary to get this program on track. It cannot be understated how big this problem is, both in terms of cost and scale. But a modern EHR is necessary if we want VA to be able to provide world-class health care and for its providers and veterans to be able to access new healthcare technology. It is clear that we need to give VA and Congress more tools to manage and oversee this program. I look forward to continuing to work with my House and Senate colleagues to ensure that we get this bill finalized and enacted into law as soon as possible. And I thank you, Mr. Chairman, and I yield back.
Thank you, Ranking Member Takano. I now will introduce the witnesses. First, we have Dr. Neil Evans, the Acting Executive Director of the HRM Integration Office. We also have Dr. Robert Fisher, who is the Director of the Spokane Medical Center, Mr. Scott Kelter, Director of Walla Walla Medical Center, Dr. Allison Erisman, Chief of Staff for the Columbus Ambulatory Care Center, and Ms. Tandy Nelson Brooks, Associate Director of the Roseburg Medical Center. If each of you can rise and raise your right hand, please. Do you solemnly swear under penalty of perjury that your testimony you're about to provide is the truth, the whole truth, and nothing but the truth? The witnesses have all responded in the affirmative, and let the record reflect as such. Dr. Evans, you are now recognized for 5 minutes for your opening statement.
Thank you very much. Good morning, Chairman Boss, Ranking Member Takano, and all distinguished members of this committee. Thank you for this opportunity to testify. As you've just heard, accompanying me today are the leaders of our facilities, Mr. Scott Kelter, Medical Center Director of the John M. Rainwright VA Medical Center in Walla Walla, Dr. Rob Fisher, Medical Center Director of the Mann Grant Staff, VA Medical Center in Spokane, Washington, Ms. Tandy Nelson Brooks, Associate Director of the Roseburg VA Healthcare System, and Dr. Allison Aaronsman, Chief of Staff of the VA Central Ohio Healthcare System in Columbus. I'm very grateful that they have been able to travel to join us today. Local medical center and VISN leadership, and for that matter, VA frontline staff and clinicians are the most important members of our community when it comes to successfully implementing a new electronic health record in VA, and their perspectives are critical. But first, I'd like to take a step back. As you're aware, and have just heard, VA needs to modernize its electronic health record system, and the department remains steadfast in its commitment to doing so. The replacement of VA's EHR is one of the most complex health IT projects ever undertaken. The project will impact more than 300,000 VA employees and more than 100,000 trainees who will one day use the new system every year, and more than 7 million veterans whose care will be orchestrated and documented within the system every year. But I should emphasize that this is much more than just a technology project. The EHR change, by its very nature, requires VA to revisit, reconsider, and where possible, standardize clinical processes and workflows. Electronic health records profoundly impact operations, including how care is delivered in the modern healthcare system, how providers access the information that they need, how instructions for care, also known as orders, are transmitted and received within the hospital, how highly complex care is organized in our intensive care units, how surgeries are successfully planned and completed, how prescriptions are ordered and delivered. Getting this right requires a massive team effort across the VA enterprise, attention to detail, effective communication, and consistent execution. In fact, as has already been mentioned, the suite of technologies that make up a modern electronic health record are just part of a larger ecosystem of technologies needed by VA to enhance the quality and safety of healthcare delivery. It's this entire suite of technologies, both the federal EHR and other critical health information technologies, that need to be modernized and integrated effectively to simplify the healthcare experience for veterans and VA staff and to enhance standardization across VA's enterprise. As you're aware, VA is implementing the very same electronic health record solution as the Department of Defense, U.S. Coast Guard, and National Oceanic and Atmospheric Administration. And this system is often referred to as the federal EHR. DoD completed their deployment in the continental United States, and they are still going to go live at the James A. Lovell Federal Healthcare Center in North Chicago, Illinois, as well as their outside of the continental United States sites. Together, we are planning an implementation of the record in North Chicago with a go-live currently planned in spring of 2024. In VA, the federal EHR is in use at 5 VA medical centers, 22 community-based outpatient centers, and 52 remote sites, such as call centers and telehealth hubs, that support the facilities led by the individuals to my left. We have been listening to veterans, clinicians, and frontline leaders, such as my colleagues here at this table, and in doing so, it became clear that the federal EHR was not and is not meeting expectations. Therefore, in April of 2023, VA announced a program reset, halting work on future deployments except for the Lovell Federal Healthcare Center. And as a result, we are now focusing on delivering the improvements needed for our current system users while also preparing the enterprise for future deployment successes. Staff productivity levels, revenue collections, technical system performance, user adoption and satisfaction, and more require dedicated attention and positive improvements before deployments resume at full pace. VA has organized its work during this program reset into 3-month increments and just completed its first increment on August 31st. Initial efforts focused on planning and making necessary system configuration changes, improving the technical stability of the system, enhancing user support and ticket management, addressing communications within VA, and developing a larger cohort of VA experts who can support the new system in the years to come. I suspect you'll hear from my colleagues that some of the necessary improvements they've been asking for are starting to be seen, but that there is still much to be done before we will be ready to publish a new schedule and proceed with deployments across the rest of the VA healthcare system. I am appreciative of the frontline leaders you see represented here. As I mentioned earlier, switching to a new EHR requires resiliency and demands a lot from staff. Frontline leaders, such as my colleagues here, are the cornerstone of any successful transition and are best equipped to support and lead staff through the process. Their remarks will follow, and I look forward to hearing those.
Thank you, Dr. Evans. The written statement of Dr. Evans will be entered into the hearing record. Dr. Fisher, you are now recognized for 2 minutes for your opening remarks.
Good morning, Chairman Bost, Ranking Member Takano, and distinguished members of the committee. We are approaching the 3-year implementation anniversary of the Oracle Cerner electronic health record at Man-Grantstaff VA Medical Center in Spokane, Washington, and our clinics in Wenatchee, Washington, Coeur d'Alene and Sandpoint, Idaho, and Libby, Montana. I would like to take this opportunity to recognize the extraordinary efforts and dedication of our employees. In January of 2020, during intense preparations to go live with the Cerner EHR, COVID-19 hit the West Coast of the United States. In April, our staff evacuated 41 patients testing positive for COVID-19 from our local Washington State Veterans Home to Man-Grantstaff for enhanced acute care that unquestionably saved many lives. Man-Grantstaff went live with Cerner in October of that year, 2 months before the country experienced its historic peak in COVID-19 hospitalizations. Since implementation, our employees have recorded, investigated, and mitigated over 1,600 Oracle Cerner-related patient safety events. They reviewed for potential intervention and mitigation more than 28,000 medical orders that populated the electronic health record queues when they did not execute successfully as anticipated. Our staff has entered 15,000 break-fix incident tickets and 3,000 change requests since initial implementation. They have been engaged in continuous EHR process improvement through collaboration with peers, facility teams, risk management, patient safety, Vision 20, other live sites, VA Central Office, and Oracle Cerner. The diligence and resilience and often bravery of our staff in transitioning to a challenging new electronic health record during a deadly worldwide pandemic is absolutely nothing short of extraordinary. Their continued engagement in identifying gaps in training and functionality over the last 3 years is a testament to the high quality of our staff and their dedication to veterans' health. On behalf of the men and women of Man-Grantstaff VA Medical Center, please accept our gratitude for your continued support of veterans and our employees who serve them and have gone way above and beyond. Thank you very much.
Thank you, Dr. Fisher. Mr. Kelder, you're now recognized for 2 minutes for your opening remarks.
Thank you, and good morning, Chairman Bost, Ranking Member Takano, and distinguished members of the committee. Thank you for your engagement in the EHR modernization process and your commitment to veterans. Having now used the Cerner Millennium EHR for 18 months, the VA Medical Center in Walla Walla, Washington is recovering toward our pre-Cerner productivity, but is still not as efficient as we were prior to Cerner go live in 2022. Clinical staff are working long days, but are making improvements in efficiency and productivity. From 2022 to 2023, primary care providers' time per patient in the medical record decreased by 10%, and they're seeing 24% more patients. Patient satisfaction with their appointment date and time also improved 7% throughout 2023. At VA Walla Walla, we added a modest number of permanent staff, 4% of our total staffing, to meet the demands of utilizing the Cerner Millennium platform, including nurses, pharmacy staff, charge analysts, health informaticists, and an additional patient safety manager. Along with additional support from our network and the National EHRM Supplemental Staffing Unit, this has been sufficient to continue operations, but VA delivered care remains at 80% of our pre-Cerner levels. The number of Cerner-related patient safety reports submitted by staff has declined by 73% from the initial spike after go live, but remains 38% above pre-Cerner levels, while staff still utilize workarounds outside of the software's designed workflow to complete tasks. We're pleased with the intent of this reset, enabling VA and Oracle Cerner to fix issues in the EHR, redirecting resources from deployment to work on optimizing the EHR at medical centers where it's currently in use. Veterans deserve the very best health care, and we're committed to delivering that for them. I'm optimistic about the eventual success of a modernized EHR within the Veterans Health Administration. I look forward to any questions you have.
Thank you, Mr. Kelton. Dr. Erisman, you're now recognized for 2 minutes.
Chairman Bost, Ranking Member Takano, distinguished Congresspeople, thank you for the opportunity to address the current state of the VA healthcare system in Central Ohio. I'm a physician and the Chief of Staff, and I'm here to represent our hardworking, resilient, and incredibly dedicated team and the amazing veterans, many such as yourself, that we serve. The past 2 years have been incredibly challenging. We are proud that we have developed an extensive preparatory plan. We increased our staffing. We set aggressive goals to try to reach our pre-deployment productivity and access. We have unfortunately found that the new electronic health records has largely provided no meaningful improvements in safety, efficiency, or communication. Our clinicians are exhausted, sometimes tearful, and frankly distressed that they're not able to provide the level of care that they could in 2019. Imagine being a doctor in Columbus and receiving a critical message about a patient you have never seen who's admitted to a Department of Defense site thousands of miles away because his provider has a similar name. Imagine being an optometrist and finding an eyeglass prescription that has your signature, but you know you never signed. Imagine being a social worker and being unable to print a transfer summary for a patient that is decompensating and needs a higher level of care. These are not possibilities. It has been the reality for our team in Columbus. While our productivity is nearing what it was pre-deployment, it remains 84% of what it was pre-pandemic. Our collections are down 48%. Joint patient safety reporting is nearly threefold what it was before we went live, with over 70% of events attributed to the electronic health record. Our staff have spent over 8,000 hours on clinical lookbacks since go live. Despite these challenges, our staff continues to persevere, working longer hours and manually completing workarounds to protect veterans every day. We are proud of our innovative culture in Columbus. We're concerned that current strategies and product are not yet adequate nor scalable. We understand we can't flip the switch and go back to the legacy system, although there are days that would be our preference. We hope for a dynamic, intuitive, and adaptable system that meets the unique needs of veterans. This will take time, resources, and a commitment for all our stakeholders. Thank you.
Thank you, Doctor. Ms. Nelson Brooks, you're recognized for 2 minutes of your opening statement.
Thank you. Chairman Bost, Ranking Member Takano, and distinguished members of the committee, thank you for the opportunity to speak today. The Roseburg VA is a rural facility comprised of 5 sites of care, serving more than 36,000 veterans in Southern Oregon and Northern California. On June 11th, 2022, the Roseburg VA made the switch from the legacy system to the new EHR. Under ideal conditions, implementing a new medical record system is challenging. For a facility challenged with delivering care in a rural setting, the transition to the new EHR was difficult. Post-go live, we saw increases in wait times, turnover of staff, and a decrease in patient satisfaction scores. In a survey of Roseburg VA staff conducted last April, 86% strongly disagreed with future deployments of the EHR in its current state, as it does not increase efficiency, improve patient safety, or meet expectations. I'm happy to provide the committee with specific examples. However, these issues were elevated to leadership within the department, who heard the concerns of staff, deferred to their expertise, and implemented the reset. We applaud their commitment to getting it right, but it's not right yet, and our facility has adapted to ensure we continue to deliver safe, quality care. Since go live, our facility has increased staffing, supported frontline staff, and expanded care models. 15 months in, we've seen improvements in staff level of comfort in the new EHR. Prescription fill times have decreased, and productivity has increased, but has not returned to baseline. We are moving in the right direction. However, the system in its current state is not ready for additional deployments. We are optimistic and committed to enhancing the system. In sum, our employees are the backbone of the organization. Their reluctance to simplify illustrates their commitment to our high reliability principles and the delivery of safe, effective, quality care. Thank you to the committee for your advocacy on behalf of our veterans.
Thank you, Ms. Nelson Brooks. And before we go further on to questions, at the VA's request, I would like to enter into the record for the hearing statement of Dr. Teresa Boyd, the Director of Vision 20. Without objection, so entered. And now we're going to go to questions, but before I go to questions, I want to make one statement to each one of you. Please deliver the message back to your employees that we know they're doing the best they possibly can and a very, very hard time in their careers. And we want to get this right. So I will go to questions first. Dr. Ersman, what impact does Cerner's EHR had on the delivery of care to veterans, especially how many veterans you can treat in a day, and how has your team dealt with that?
Thank you for the question. Initially, it had quite an impact on the number of patients we could treat a day. The answer is somewhat diverse depending on what service we're considering. So we were able to regain our productivity in our surgical clinics by August. We went live in April of last year. In other places, we still haven't quite reached what our productivity was before, particularly in primary care. The gains have been much more incremental and the slope much more shallow. So we're approaching about 80% to 85% in some of those services.
Right, can you also let me know about how the system downtime, Oracle and Dr. Evans' teams are reporting dramatic improvements? Are your staff seeing dramatic improvements?
Is that a question for me as well?
Yes, please.
So we've seen over the past 6 months, there have been fewer total downtimes, so total outages. Our staff still is seeing at least once a month incidents that leads to having to go to downtime procedures. So functionally, for those trying to take care of patients when they need to put pen to paper, that has still happened. It actually happened 2 times in the past 2 weeks.
Okay. I'm going to stay with you for all my questions, and then I think others will be going to the others. Is your facility running better than it was before the Cerner EHR was implemented?
Operationally, I think our facility is running quite well. I would say that operating with the Cerner record has posed new and interesting challenges, and we've had to dedicate resources that otherwise would have been dedicated to strategies to improve care.
Well, it sounds like you've done what you could do to make what you've been handed work to the best of your ability. And some of the big improvements will be beyond your control because it's going to be Cerner that's got to come in and right the wrong. In the current situation, is it a Band-Aid or is it sustainable? How long, and if it's not sustainable, how long is it sustainable?
I'm sorry, can you clarify
Yeah,
the question?
basically, where you're fixing now, are you going to be able to keep it together, or is it going to have to be changed tremendously?
It's a great question. We are taking care of the veterans in Central Ohio, and I think we're doing an amazing job, but at what cost? It's cost a tremendous amount in terms of additional staff, in terms of additional overtime, and in terms of, I think, a degree of moral distress among our providers.
This isn't on my questions, but it's on my mind, okay? Right now, we are turning up the PACT Act. Your workload's going to get a lot bigger. Are you going to be able to handle the workload that we are sending to you through the PACT Act with the system and the situation that we're with right now?
I have a bit of good news in that Columbus is really leading our region and I think our nation in how we've addressed patients with toxic exposure screenings, and we have no patients that are waiting for their follow-up exams for toxic exposure screening. But I agree, if it increases our enrollments, it will be a challenge in the future.
Let me tell you that we want to thank you for being here today. I want to say thank you for you and your staff, like I said. I know we're going to have a whole lot of other people that need to ask questions here, so I'm going to yield to the ranking member, and so we can go on with the rest of the questions.
Thank you, Chairman Bost. Yesterday, we received the quarterly patient safety data that was mandated by Representative Frank Mervan's EHR Transparency Act in the last Congress. And I have to say I was alarmed to see that there are quite a few of the reports from our facilities on patients what's alarming is that that we're seeing a few reports of facilities receiving reports on patients at other facilities. I thought that VA told us over a year ago that this issue had been fixed. Now, Dr. Ahrensman, you mentioned this particular issue in your opening statement. Can you give us an indication of how often this situation is occurring, where facilities are receiving reports on patients at other facilities?
Thank you. I believe I mentioned in my opening statement that there was an increase in patient safety reports. I have heard that occasionally they have been sent to erroneous sites. I don't have the documentation as I don't actually have access to that system. It's a highly protected system given the obvious privacy concerns for anyone involved. I can say that there have been an increase in patient safety reports, but I want to be clear, this is something we often celebrate and I think of as a good thing because these are things that are recognized as dangers to patients. It doesn't necessarily mean there has been a catastrophic event. It means that something has been recognized as a potential patient safety concern. So for a high reliability organization, we want people to speak up and we encourage them to speak up. So while it's concerning and while it's frustrating to me that we're spending a lot of time addressing these, I'm proud of our staff and I think that it's potentially a benefit.
Excuse me, Dr. Aronson. What I'm talking about are patient messages.
Oh, sorry. Okay.
Patient messages. So what specifically we're concerned about is facilities receiving reports on patients at other facilities.
Thank you for that clarification.
Okay, great.
So
I mean, can you comment on how frequently this is occurring?
I hear about it happening on a weekly basis.
On a weekly basis? Okay. Dr. Evans, can you shed light on why this continues to be a problem?
So I think, of course, we don't want to ever see that happen. We want we want orders and messages to be delivered to the right recipient at the right facility. As we're deploying an enterprise EHR that is a single enterprise EHR with the Department of Defense, Coast Guard, NOAA, and VA, we're moving into a very different paradigm than VA has been used to, where care was constrained within the local VISTA instance. And so we spend a lot of time working on optimizing the configurations of the record to try to make it such that that doesn't happen, that messages are not going to the wrong facility or wrong individual. It is a focus area of some of the configuration changes that we're doing in the reset. This is, in some forms, there are real significant advantages to having an enterprise electronic health record, a single electronic health record that works for the entire VA healthcare system. We'll be able to better share resources between our facilities. We'll be able to deliver telehealth care, provide support from tele-ICU physicians to facilities all across the country with less burden. There is an advantage. That advantage comes with a corresponding risk. And that risk is that we now have to function as a healthcare system with over 300,000 employees at the end of this in the same system. And so we are working on how do we mitigate that risk, how do we prevent that. I think there's been improvement, but we're not where we need to be, obviously, based on what you just heard from Dr. Ahrensman.
Well, Dr. Evans, can you assure me that VA and Oracle Cerner, they're looking at a way to fix this problem?
Yes, to address this problem, absolutely.
Well, great. Well, you know, I just want to, again, really thank Mr. Mervan for the EHR Transparency Act. It's giving us, already it's paying dividends in terms of giving us important reporting and enabling us to do better congressional oversight. But I certainly hope we do get this issue fixed. I yield back, Mr. Chairman.
Gentleman yields back. Thank you, Ranking Member. Representative Radewagen, you're now recognized.
Talofa lava. I want to thank Chairman Bost and Ranking Member Takano for holding this hearing today, and I thank the witnesses for being here. So, Mr. Kelter, how long did it take after Cerner was implemented at your facility for patient volumes to go back to 80% of normal? Please answer that in terms of primary care and specialties. I understand some of your departments are very large, while some are very small.
Similar to what Dr. Ahrensman described, our specialty care was fairly quick to recover, and the record didn't affect their throughput very much. Our our laboratory service almost immediately saw benefits to the system, and in fact, our laboratory service is more productive and the system has made them more efficient. Primary care, as one of our largest departments, has had a very, also similar to Columbus, has had a slow slope. It took several months we started very slow with just a couple of patients a day as physicians and other members of the team learned the record, and incrementally grew from 2 to 4 to 6 to 8 to 10 patients a day. So it really has been, it probably took about a year before they were at the level, about the level that they're at now.
Okay. So, Mr. Kelter, how have your wait times been impacted, and how much more care are you sending out to the community compared to before Cerner?
The wait times initially increased significantly. Our patient care going out to the community was nearly double for some period of time. Our community care office is pretty much caught back up to the consult volume that we were at prior to when those consults built up in the Cerner Go Live timeframe. Part of that has been due to the system itself and the efficiencies of the system, and part of that has been due to staffing variabilities that are unrelated to Cerner. So Again, it has taken, through a variety of factors, again, a little bit over a year to catch up and get back to that, as well as those departments, both the primary care department and our community care coordination department. Quite a bit of work, not only in staffing, but in developing their own processes and working through those things to improve. They have worked extremely hard to get to where we are, and also to help break those barriers to make it easier and to share those lessons forward to other sites to make it easier for sites that will deploy after us.
So how many more staff have you needed to hire since you got Cerner, and what areas have you hired them in?
We have increased staff in our community care department specifically to help with the coordination of consults. We have added a patient safety manager, so we've gone from 1 to 2 patient safety managers. We have increased some of our, essentially the equivalent of 1 primary care team. Some of those increases are coupled with the normal recruitment challenges that we have as well. So increasing the authorization doesn't necessarily mean a rapid increase in staff.
How about your medical collections, the co-pays and insurance payments? How has Cerner affected them?
We have had a very limited ability to do third-party collections, and our collections have been significantly decreased. We have very little revenue to show, and that's done through our a third-party billing office. That's not done at the medical center. That's done at the network level.
So you're here to speak for your staff. How do they feel about the Cerner system? What are they saying in surveys and to you directly?
The majority of staff are still frustrated at the amount of time and for many, it's essentially the process time and the number of clicks for to get through a process where something might have taken 6 to 10 clicks before and now takes 30 to 50, and so the process time for many things is still double or triple what it was.
Thank you, Mr. Chairman. I yield back.
Gentlewoman yields back. Representative Van, you're recognized.
So my question is, the commonality is the challenges that you're facing, and we can't go back in time. If you could each just give me a little bit of perspective, if you think it is the capacity of the new system, if it was training, just very simply, what do you think led us to get to this point that you're before Congress because of the slow rollout and the risk that it provides?
I suspect you're interested in the perspective from the medical center leadership.
Correct.
Thank you for the question. It is a rather complicated question. I think that there are a number of facets that are involved in what's led us to this point. The training that our staff initially received from Cerner was not what we expected and did not adequately prepare staff to be able to function effectively and efficiently in the medical record system. In addition to that, there were specific things that were not included in the medical record to take into account some of the complexities of care that the VA delivers. Cerner is a commercial off-the-shelf product not designed for the VA and does not take into account specific programs such as our caregiver support, our homeless program, and other programs along those lines. Similarly with DOD, we are very different. And then lastly, what I would say is that each medical center is different and is unique, and their capacity to handle change of this scale is very individualized.
Can I hone in on that? Can you tell me what you mean by the capacity of each individual organization? And just kind of explain just a moment of that.
Absolutely. So the Roseburg VA is very rural. As a rural site, we're challenged with recruitment and retention of staff. We currently have a 40% vacancy rate in our primary care providers. Our position is very different from Columbus, where Columbus may not have been struggling with high vacancy rates in primary care and mental health. In addition to that, as a facility, we've had turnover in our leadership team. I'm new to the Roseburg VA, having been there less than 2 years, and the new medical center director, who really wanted to be here but could not be here today, began in April. So as a facility, we've experienced turnover in our leadership team.
Thank you. Anyone else?
I would say one of the root causes is related to Oracle Cerner's lack of appreciation for the complexity of VA operations when we began this journey. I would also say that their training.
Can I ask? So,
Sure.
just interrupt, I'm going to follow up on that. So we've transitioned from Cerner to Oracle. Consistently, as chairman of Technology Modernization last year, there has been an absence of you sitting at the table trying to give your opinion. Has Oracle changed that? Have you had an opportunity, or has Oracle changed your input into these situations?
I think that's an excellent question, sir. Don't forget, we're in a reset period now, and so the conditions and the environment has changed. Now we're starting to rev up meetings with both Ermio and Oracle Cerner, which is a consequence of this reset. And so it'll be hard to say today what a month from now will look like when we're more into normal operations, improvements are being made, and I suspect we'll get more and more engagement from Oracle Cerner.
Thank you. Mr. Evans, you talked about the ecosystem of technology that goes into the support, or I interpret it as support into the electronic medical records. Can you define what you mean by that?
Sure. I think sometimes we think together that changing the EHR from VISTA CPRS, which we've been using in VA and are still successfully using in much of VA, to the federal EHR, the Oracle record, is the sum total of what we need to modernize health information technologies to support a modern VA. The EHR in many ways serves as the equivalent of the operating system of a health information technology ecosystem. There are other critical applications, telehealth applications, connected, the bedside monitors that are in an intensive care unit, measuring real-time EKGs or telemetry, new clinical decision support applications.
So does the new system does it not include those systems? Are they not working in conjunction with each other?
I think in my opening statement when I mentioned that, I think in part of the promise of a modern commercial electronic health record is that we will more easily be able to integrate and deliver connected technologies that will enhance the function of the electronic health record. And we currently have many interfaced technologies supporting the medical centers that you see represented at my left. So I don't think that that's a problem. I was characterizing that as an important part of the overall modernization journey that we're on. We're modernizing the EHR as well as the rest of our health information technologies that support and work in an integrated fashion with that electronic health record.
Thank you. With that, I yield back.
General Berkman, you're recognized. Thank you, Mr. Chairman. Listening to the testimony and the questions reminds me of an old saying about trying to fit a square peg into a round hole. And I would suggest to you the round hole is how the VA medical system has been delivering services to the veterans. The square peg is the new EHR. Okay, now you got two choices. You got a square peg, a new system, and you got the existing ways you're doing business, the round hole. The question is, how do you make the two fit? Because they have to fit. And any time to use the square peg as the example, if you start shaving it to fit the round hole, you're going to cut off some of your capabilities and make the whole system not work. That's just how that evolution works. So, Dr. Evans, Just a thought here, because I heard you say in your opening testimony, where possible, standardize, and then you went on from there. Standardization is the key to controlling costs, standardizing care for everyone, ultimately standardizing the ability of your physicians and providers to actually do their job, and ultimately the long-term success of the new, if you will, enterprise system. So when it comes to the standardization, I ask anybody to provide comment, how are you working to standardize roles and clinical processes at the sites rather than try to make the EHR system work for your existing processes? Anybody want to offer comment?
Yeah, I'll start, and then I'd love to hear some thoughts from those to my left. But first of all, I completely agree, and I would argue that we have a square peg and many round holes, not just a square peg and a single round hole. And
The VA is the round hole.
correct. And if we're trying to put a square peg, a single enterprise electronic health record, we are having to fit it to workflows which may not be the same at 165 different medical centers.
Now, I'm going to just interject for a second here because in a former life, I was a commercial airline pilot, and we had 4,000 pilots on our seniority list. We all did things the same way, regardless of what aircraft we were flying. There was a little nuance in checklists and operation. So tell me again why it's going to be so different across the VA.
I'm not. I'm saying that we need to standardize. I fully agree with you that in order for us to successfully deliver an enterprise electronic health record, one of the significant tasks in front of us as part of this reset is standardizing how we deliver care, whether that be primary care.
What's the standardization? I would guess the ball is in your court on that because you are the providers. All this is a tool, if you will.
Correct.
Right? So, because we can eat up all the time here. Anybody else want to make any comments on the standardization as you try to move forward in, number one, up in the quality of the healthcare and the timeliness and all of that across the entire system, but the challenges you have in standardizing? Anybody?
So as we learn new things about the medical record, the Cerner Millennium product, and we continue to learn more things about it every month, across the live sites, we have a network.
When you learn new things, what then is the way of sharing the new things so that a brush fire doesn't become a forest fire in this case? What is the mechanism that the VA is using to communicate across and to work with Oracle to iron out the inevitable kinks in installing a new system?
We have frequent recurring meetings across the 5 live sites, primarily within Vision 20 and including Vision 10, as well as frequent and recurring meetings with Cerner executives. So each time we discover something, our immediate question is, what are the other sites doing? And how do we share what we've learned, and how do we determine what's the best way to approach that? And then engage EHR-MIO and Oracle Cerner with that solution.
Okay, thank you. Mr. Chairman, I see my time is up. I yield back.
Thank you. Representative Brownlee.
Thank you, Mr. Chairman. Just to piggyback on this conversation, it seems as though getting standardization across the VA is a task, an objective that I'm not sure is possible to achieve, honestly. I mean, since, we have said, I've been on this committee for 10 years, and we've always said if you've seen one VA, you've seen one VA, and each medical center has a lot of autonomy, and I just don't know. To me, that is like the biggest cultural shift that could possibly occur within the VA is to gain standardization. So it makes me worried that that is an essential key to making this all work. But I'm not going to ask a question around that. I'm going to move on. So, so the EHR has been deployed, and the Coast Guard and NOAA, it sounds like successfully, understanding that there probably is standardization, across those entities. The DoD has done half of their facilities have deployed the EHR. So I guess it sounds to me that in all of those locations you're having success. And is it just the standardization? Is that the key essential difference between VA not having success and they having success?
Yes, good question. So the DoD is, I think, over 90% complete. The only sites that they have not deployed are outside of the continental United States and the James A. Lovell Federal Healthcare Center in North Chicago. I think there are several factors. Again, we are different healthcare systems, but healthcare is healthcare. And so, one of the challenges that you face in deploying an electronic health record is the tension between needing to deploy the health record and needing to optimize it such that it is fit for purpose for how you deliver care in your healthcare system. I think DoD was probably further along in the standardization journey than we were when they started. And they were moving from an electronic health record where I don't know that there was as much autonomy locally, and nor was there as much sort of satisfaction with the EHR that they were moving from to the new EHR. So I do think that a commitment to a baseline, here is how the record will be configured and how we need to move forward, was a part of the success story for those three health systems that you mentioned. I think, however, when you deploy an electronic health record, you're never done. There is always a tension between pushing forward with the deployment, but doing the optimization. And it's really as part of this reset, we are choosing, rightfully so, absolutely have to get some of that optimization work done now, to take the time to do that so that we can deploy a more standardized EHR that will meet the needs of our facilities moving forward.
Thank you for that. And I assume that the deployment of those three organizations, they did that on budget, didn't have any cost overruns in order to do it?
Coast Guard and NOAA are very small organizations, and their deployments were supported by the DoD. The DoD took a very, very similar pause, reset. I didn't call it a reset, but what we're in the middle of. Interestingly, when they came out of that, they addressed many of the same challenges, standardizing, deciding what the baseline is, fixing issues around training, revisiting their deployment methodology. As they came out of their pause, they were able to accelerate their deployments. They revisited the structure by how they went live. And so I can't comment exactly on where they are with regard to their budget, but they did pick up speed by spending the time to do things during an equivalent of a reset. By doing those things right, it actually helped them on the back end.
I guess there's hope that the VA, the same thing can happen within the VA. I appreciate your honesty and your written testimony that you don't have a firm timeline for the completion of the project. I appreciate that very, very much. There have been many who say it's going to take more than 10 years. I'm wondering if you have any sense of where we might be without making a hard commitment.
I think, as I just mentioned, I think this is actually an important part of the reset. Part of the reset as we move towards thinking about reset start needs to be, because we've promised that we will publish a schedule that we can stand behind at the end of reset. There's a lot of analysis that needs to go into understanding what that is, and to frankly develop a schedule in partnership with our field leadership that makes sense. Should we be going live concurrently at medical centers that share resources and refer between each other? How do we want to revisit what that schedule looks like? And so that work is ongoing right now to analyze what the constraints are to develop a new schedule. We want to do this right. And so I feel an urgency. It's hard for me to commit to say where this is going to fit from a timeline. That's work that we need to do as part of the reset, and I look forward to continuing conversations with this committee on that topic.
Thank you very much. I yield back, Mr. Chairman.
Thank you. Mr. Rosendale.
Thank you very much, Mr. Chair. And thank all the witnesses for coming here to D.C. to testify and answer questions. I've made it my mission to provide proper oversight of the Oracle Cerner electronic health record system and ensure that veterans are not being put in harm's way and that taxpayers do not continue to waste billions of dollars. Billions of dollars. Dr. Fisher, are you able to treat as many veterans today as you were before the Cerner system was introduced?
No, sir.
Okay. If so, when do you anticipate that you would be able to return to that level? Any estimate?
I'm optimistic that with Dr. Evans and the efforts of the agency focused on improvement, once that gains appreciable traction, that I would expect we will therefore gain more productivity.
So we can't estimate.
It would be difficult for me to estimate.
Okay. Dr. Fisher, I understand you have added about 20% more staff to treat the same number of patients, or, as you say, a lower number of patients. Please help me to understand where the additional staff are working and why the Cerner EHR created the need for them.
Well, overall, we have added 20% more staff and 15% more clinical providers. I haven't broken it down by specific departments. We've added to safety, we've added to quality, we've tripled our informatics staff, we have more administrative staff, and where we...
All of this improvement in addition to staffing, and yet your client treatment, the number of patients that you're treating is going down.
Well, it's not going down, it's simply not increasing at a great rate. We're about 70% of efficiency from prior to go live. A year ago, we were at 50%. So we are seeing slow and incremental improvements, but we've told our staff to move at the speed of safety, and I believe that's what they're doing.
So what is the sum total of additional expenses due to staffing or investments that have been measured since the introduction of Cerner?
The annual rate for roughly 200 more staff is in the multi-million-dollar range, sir.
Did Cerner cover any of that additional expense?
I don't know what the source, I believe VACO covered those expenses, sir.
So that's
Central
coming
office.
out of Veterans Affairs budget.
That's my understanding.
Okay. Earlier this year, you were projecting about a $35 million deficit. There was a public controversy about whether the VISN was going to withdraw the funding that allows you to balance your budget, forcing you to lay staff off. Secretary McDonough even had to intervene and pledge support. Was your budget problem resolved? And if so, how?
It was resolved. The VISN and VACO covered a $27 million deficit. We had some supplementary funding because of difficulty with third-party payers. We've got some activation funds for leases we're about to execute. So yes, the deficit was covered in total, and it always is every year.
So let me make sure I understand. Oracle Cerner is continuing to receive their full payments, billions of dollars worth of payments, and we are running budget problems at the facility, and even though Oracle Cerner is not providing the work that they contracted for and is continuing to be paid, and it's costing additional expense at the medical facility, they're staying whole and the taxpayers are paying additional money for the additional staff. Is that fairly accurate?
I think that's fair.
Mr. Chair, I yield back.
Thank you. The gentleman yields back. Ms. Ramirez.
Thank you, Chairman Boston, Ranking Member Takano. I want to also thank every witness that's here today. I am one of the newer members in the committee, so I've appreciated really learning from my colleagues here, and certainly I know that this has been a hearing we've had before. The contract with Oracle Center and its implementation, the challenges really get us to a system of a root problem. I think it's deeper. And I think we know that there's been failures at every level, unfortunately, in the VA regarding veterans and healthcare and medical records. I recently, during August district work period, convened a series of roundtables that brought together veterans from all over my district, from DuPage to Chicago. And I asked the veterans, tell me what you're experiencing, what are the problems you are seeing, and what are the possible solutions that you think we should be implementing. Unsurprisingly, a disproportionate amount of their feedback was related to healthcare. The veterans I heard from shared their concerns, including that veterans were outright denied healthcare, expressing that the VA healthcare system needs to be better for veterans in general, and that the VA cannot successfully transfer medical records between the Department of Defense and the VA. I must have heard that at least 10 times. This signals to me that we currently have in place, what we have in place for veterans is failing at multiple levels. And it's not just the electronic health medical record modernization that's failing, but the entire healthcare system at the VA still needs some significant improvements. My hope is that as we continue to provide oversight of the electronic health record modernization efforts, that we come together to address the root causes in the VA healthcare system and what they're facing. So, Mr. Evans, I would like to get clarity on your efforts to improve the health records. I would ask you, can you tell me a little bit of how you're soliciting feedback to improve the EHRM efforts? And the second part to that question would be, what groups are you engaging in, and how are you deciding to engage these groups?
An excellent question, and I appreciate your comments. I've been a primary care provider in VA for 22 years and still see patients every week, and I am incredibly proud of our healthcare system and agree with you that we need to be responsive to the veterans who are seeking care from us. I will also say that when I started 22 years ago, the VA, oftentimes I couldn't find records from the DoD. But with the Joint Longitudinal Viewer, I cannot remember a time in the last probably 5 to 10 years that I couldn't find a piece of information from the Department of Defense that I needed to take care of a patient. We are sharing records between the DoD and all VA sites, and it is visible in the Joint Longitudinal Viewer. Now, we sometimes run into trouble where somebody doesn't actually know where to look for that. And that is something we continue to work to improve to make sure that all of our staff are available, that are aware that that information is available. But it is available. It will be even more available and even easier to access as we deploy the federal EHR, a single record between DoD and VA.
Dr.
On
Evans,
the topic of your question.
my time is running out though, so I would love to hear, I think it's important for the veterans to hear how you're soliciting some of that feedback.
Absolutely, absolutely. So with regard to soliciting feedback, we do a regular survey of federal EHR users. And by that I mean staff. It is a standard set of survey questions that are provided and actually used across the healthcare industry by, they're called the KLAS questions. And that's one way we're seeking feedback. But we're also regularly engaged with end users of the system as we're resolving problems and getting input from folks in the field. Specifically for veterans, we regularly survey veterans about their satisfaction through a survey called the SHEP survey, survey of healthcare experiences, and through our V-Signals platform. So after clinic visits, we send satisfaction surveys, and we read and pay attention to that feedback, including when there are suggestions about how we should improve our electronic health systems.
Thank you, Dr. Evans. I know I'm running out of time. Just a quick yes or no question. This is about oversight of the system improvements. It's imperative that there's a third party that can objectively provide some of that feedback. Is there any third-party organization providing oversight or plans to contract with a third-party organization? That's a yes or no.
There is work that's happening at the enterprise level around contract validation and verification from independent parties, yes.
Thank you, Chairman. I yield back. Thank you, Dr. Evans.
Dr. Mel makes you're recognized.
Thank you, Mr. Chair. I'd like to thank the committee and all of the witnesses for appearing before us today. And let me say that I provided care as a physician and a nurse when I was both active duty and then as a volunteer in our VA hospitals and institutions. Our VA in Iowa City provides some of the best care around. And I've also had the opportunity, I'm so ancient that have gone from paper records to electronic health records, and certainly know of its main dysfunction, which is a reduction in productivity and a reduction in the interaction and face-to-face interaction of providers with their patients. So having said that, and having been through transitions from one type of EHR to another, when it's necessary to be system-wide, even though I'm a specialist ophthalmologist, which another EHR would be much more adapted to my use, I know how difficult it can be in order to institute EHR throughout a system, and especially one as vast as the VA system, the VA healthcare system. However, the rollout was in 5 VA medical centers, and there had already been experience with an electronic health record system. So this is for all of our medical leaders here. Has your facility's overall experience with the Oracle Cerner electronic health record changed over time? And as you've realized improvements, how many of those were due to the system itself improving versus measures you and your staff did in order to adapt the system to you? And then second follow-up question is, having been both in the military and the VA, is it really that critical that we have the same system through both active duty, military medical, and VA?
Thank you for that. And I would also, to your comment about going from paper records to an electronic health system, I've had providers who did the same speculate that it is probably a more difficult conversion in a large scale from one electronic medical record to another than it was going from paper to electronic. I would say in the last year and a half, our satisfaction and our ability to use the platform to do what we need to do has improved, and it has been based on both of those factors, both the changes that have been made along the way, and it's very heartening for staff to be able to see changes that occurred because of something that they recommended or asked for in terms of a configuration change, as well as the ongoing efforts to learn how to use it better, to engage in how to optimize their own workflows, and to see those changes in, maybe going from 47 minutes to complete a task down to 42. Optimally, we'd still like to see it at half of that time, but to see those changes and improvements over time.
And that's the problem we've had all along with EHRs, and that is you're adapting your workflow to an electronic health record, an electronic system, rather than the electronic system being designed around your work, which is why productivity is reduced. And when productivity is reduced, guess what? We're delivering less care to fewer veterans. So with that, I know I ask you all to comment, but my time is running out, so I'm going to yield back.
Representative Brzezinski, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you to the panelists for being here today. I had some questions specifically around some of the challenges and how this has impacted rural healthcare. I appreciated that Ms. Nelson Brooks mentioned that obviously she services a medical center in a rural community and some of the unique challenges around interoperability with the new EHR system. And so I wanted to maybe start out by asking Dr. Evans a question related to this topic. And has anyone done an evaluation at any of those rural sites to determine if or how much the system is improving communication between the VA and community care?
First of all, the importance of our delivering care in rural parts of our country is absolutely critical. I don't think, and I think I'd be interested in Ms. Nelson Brooks' opinion on this, I don't think that the technology itself is appreciably different with regard to interfacing with community care. That is, the electronic connections to get a referral sent to a community care provider. There are differences around the sufficiency of the community care network in rural America and how we manage the capacity to deliver care to veterans in those communities, but I don't think the technology should be a barrier. Do you have any further thoughts on that?
Thank you. I agree with Dr. Evans. I don't think that there's anything within the medical record itself that has improved communication between our facility and our community care providers.
Maybe I could now switch to a different topic around veteran mental health and suicide prevention, which are two topics that have become extremely important to me. I've heard from some VA staff at the first Go Live sites that there were a lot of issues with Cerner when it comes to the behavioral health and case management applications. And so maybe this is a question for the medical center directors, and maybe I could start again with you, Ms. Nelson Brooks. What progress has been made to improve these functions?
Immediately post Go Live, we had challenges with high-risk flags not being visible in the medical record. Those have since been fixed, as well as some additional changes that were made. I'm not able to fully explain all of the changes that were made, but what I can tell you is that as a facility, we've seen marked improvement in our Charm 1 metric, which we hadn't seen the year prior. Charm 1 has to do with suicide prevention and our case management activities around suicide prevention. So we have seen improvement there.
Is there any area in particular that there hasn't been improvement that we should be working toward improvement on, if you could speak to that?
Specifically in mental health?
Yes.
None that I'm aware of, but I'll yield to my colleagues to see if they can add anything additional.
Thanks for the question. I was walking around the veteran memorials last night and thinking a lot about the mental health and all the things we try to do to help our veterans, and sometimes going above and beyond what they can expect in the community in terms of their care. We've had some challenges, I think, particularly with relation to care plans. Sometimes it's as simple as having enough space to put in enough information for an accurate care plan. That's something that I'm told is being worked on. We had some significant challenge with long-acting injectables, which are the drugs that patients who have psychoses need to take because they aren't good at necessarily taking their oral medications. And this has been something that we have seen an improvement in since Go Live.
Okay, that's great. Would anyone like to add anything else? Okay, thank you very much. I yield back, Mr. Chairman.
Gentlewoman yields back. Dr. Murphy, you're recognized.
Thank you, Mr. Chairman, and thank you all for coming today. I'll try to make these very quick and brief. I actually still use a medical record system. I have for, I guess, 20 years now. Yes, I was a dinosaur and used paper system, and there were a lot of things that were actually good. Electronic medical record system came in, number one, for billing. That was the primary source. Number two was for order entry because they thought there were too many errors going on in prescription writing, et cetera. Come to find out, yeah, errors are still occurring at the exact same rate. There's different errors when you click the wrong click to get in. Also, it was for portability of the electronic medical record. And that's an absolute, in my opinion, the best whole thing. The fact that I still see VA patients and I can't get records from a VA is inexcusable. I'm almost ineffable about your comment, Mr. Kelter, that it's 30 to 50 clicks to complete a task. 30 to 50 clicks to complete a task. That's unconscionable. That's unconscionable. And Mr. Evans, or Dr. Evans, did you say it might be 10 years until this problem is fixed?
No, I did not. That question was that specific question was around how long it was going to take us to complete the deployment from when this project began 5.5 years ago, whether we would complete the deployment within the 10-year cycle that was originally proposed.
All right, well, let me ask you this, if you will. Are you happy with the support that Oracle has provided you for Cerna? Because I'm understanding a comment made in another committee the other day that Oracle didn't think it was a big deal. Is that correct or not correct? Are you happy? You say, hey, I'm having these problems. Can you come fix it? Are they there that day, the next day? What's been their response rate?
Yes, I mean, they're highly responsive and motivated to move this forward. I think one of the things that we have identified as a critical part of our moving forward of the reset is, Oracle will do what we ask them. We need to be able to ask them to do things in a way that delivers the kind of experience that is not 30 clicks. And some of that requires internal expertise within VA with regard to informatics, partnering with their team to deliver a better experience.
All right, so that's where, in my problem, the key error is. You're asking them, they're asking you to create your own medical record system with their expertise, instead of them bringing a product to you that you can then conform to the VA. You should be able to, within just a few clicks, if somebody shows up at a VA from literally across the country, access their medical record, being able to read everything that they've done and move on. You should also have a medical record that if somebody goes out into the community, that they should be able to access. I would consider this, I've not been in the military, it's just not been my bailiwick, I've been a surgeon for 30 plus years. I would consider this an absolute failure. If you have an error rate that is higher now, an inefficiency rate higher now, 5 years afterwards, it's an absolute failure. If this were out in the private community, that company, the cord would have been cut and moved on. Cerna now, and I'm just going to be very plain with this, Cerna is losing market share in large systems. It may be gaining some in smaller systems, but the last time I checked, the VA system is the largest in the country. So my recommendation, I'll be very plain and simple with it, I think Cerna has failed you. I think it will continue to fail you, and I believe you ought to cut the cord and go to another larger system. There are systems, I use a system now that I wasn't happy with at first, but it is seamless. And I can go to another institution, boom, I can find their record. I think this is an absolute failure. I think it's putting lipstick on a pig and pouring millions, if not billions of dollars into a system that is not providing the best care for veterans, period. And I think you can keep working this system and milking it and milking it. This is not a good system for the VA Healthcare Center. So I'm incredulous that 5 years out, it seems like there's even more problems than there were to begin with. And that 5 years out, you're still having to bring people and basically rebuild a system from the beginning. That's not what the electronic medical record is supposed to be. And yes, we know there will be inefficiencies compared to being able to write something on a piece of paper and send it out. That's well documented, and I think it's accepted at this point in time. But the fact that you can't do that now 5 years out and efficiency is down 40% still is inexcusable, absolutely inexcusable. This should be, in my opinion, another system. There are other systems out there that are much better, in my opinion, that could well translate to the needs of the veteran and the VA. With that, Mr. Chairman, I'll yield back.
Thank you. Gentleman is back. Representative Shifless McCormick.
Thank you so much, Mr. Chairman, for having this hearing, and also Ranking Member Takano. I wanted to go back to the standardization issue, since it seems that standardization is intimately tied to the success of the EHR. Dr. Evans, in your testimony, you mentioned that one focus of the VA's EHR reset is to improve the federal EHR baseline. What progress have you made on the baseline EHR?
we are, again, this does get to the point of standardization. So we are currently working through items that have been identified by end users at our live sites and making those configuration changes. And I think what you heard is we are doing that in a way that is standardized across the 5 sites. There are capabilities where we may need to revisit some of the original decisions around what the baseline of the EHR looked like and possibly simplify that in order to move closer to a model approach, a recommended ideal approach for the configuration. And that work is ongoing in the next several months.
Specifically, what I was asking is, how are you measuring progress and success of the work that you've been doing to move towards standardization and also the baseline? How are you measuring that? Have you seen any improvement for what you've been doing so far?
Yeah, I don't know that I have an answer to how we're measuring it other than we are working to compare how the VA has configured its record, or how this particular record is configured, with what Oracle recommends as its ideal baseline. We're doing that work right now to compare the configurations to see whether there are lessons learned where we can move towards a more standardized and optimized configuration.
I'm assuming that the federal baseline is different from the VA's baseline. Where are you at in the establishment of the VA's enterprise-wide EHR workflow baseline?
There are a couple things that matter from a baseline perspective. There's a baseline around what are the interfacing systems that we can support at baseline. So when we deploy the electronic health record, what IV pumps, what bedside monitors can we support, what other applications that connect to the EHR are part of the approved baseline. And we've made considerable progress on essentially identifying what is that baseline of connected technologies. That will save us money over time by minimizing interface cost requirements. We're also working on the baseline of the configuration as part of our overall standardization effort, as just mentioned.
I'm very concerned that the VA appears to be focusing only on the first 5 sites, which I agree must be fixed, but it is not thinking strategically about the rest of the go-lives. I'm afraid that we're going to continue to have problems in VA and if the VA doesn't focus on its standardization needs in order to roll the system out in future sites. What steps are you taking to actually consider not just the 5 that you've rolled out, but the ones that you're going to be rolling out in the future?
Sure. When in our improvement efforts, we bring together not just representatives of the 5 sites, but the clinical councils, as well as the clinical program offices. So the clinical councils are groups of individuals who understand the healthcare delivery in their lane, whatever that might be, ambulatory care, virtual care, surgery, who are spending time making recommendations and support for how the EHR should be configured. The program offices are responsible for the national delivery of that type of care. We bring program office representation and council representation to these decisions so that when we're making a decision about how to configure things for one of the 5 live sites, we're doing so in a way that will meet the needs of the entire enterprise.
I still have concerns about the systems in place to measure success, because you can create these different practices and plans, but how do we know that it's actually going to manifest itself into a successful system? Also looking at feasibility. Have you been looking at the feasibility of having that standardization and that baseline? Do you have these systems in place? Because I haven't really heard of systems of measuring success and feasibility.
So we do have success criteria for the reset that we are developing and already measuring parts of these. I would start by saying that at the core, the system has to be rock solid from a technical perspective, up, available, with high performance for a user. There's nothing more frustrating than trying to log into a system and it's not working. So it has to work from a technical perspective. We are also, so there's the technical metrics. We're looking at user satisfaction and user adoption. Or the Oracle record has tools that we don't have available to us in CBRS Vista that can allow us to look at individual users' use of the system and identify folks who are struggling or places where workflows are inefficient. So and there are others that we're measuring, and I know we're running out of time, but looking at individual users, understanding the technical behavior, looking at productivity, as you've heard, looking at revenue collections, are areas where we're measuring metrics to demonstrate that we are improving.
Thank you, Mr. Chairman. I yield back.
Thank you. Ms. Kagan.
Thank you, Mr. Chair. I just wanted to piggyback off of Dr. Murphy's comments, and he's no longer here, so you can be very forthright. But just if you could each go down the row and just respond to what he said about, is this system failing you, and should we be pursuing another direction? Just curious.
The one comment I would like to make is that, and I will answer your question, the Joint Health Information Exchange has been one of the successful parts of this project that we've delivered. VA and DoD are now exchanging data on 3 health information exchanges. Data is exchanged with more than 90% of US hospitals. And so I actually rarely walk to the fax machine anymore. I can find the record from community providers. And so I think I just wanted to make that point. Second, as I mentioned earlier on, we are committed to moving forward. We have invested a significant amount in the success of this project. I think we're beginning to see improvements as a result of the reset. It's slow and incremental, and we expect it, and frankly, it must accelerate. But I still believe that we should proceed forward.
Okay, thank you.
The interoperability of healthcare systems between our medical center, other VA medical centers, other agencies, and private sector is extremely important. As we heard, the ability to, if one of my patients is being seen in Spokane and then needs to go to a private hospital in Spokane and then is going to come back to my medical center, I want my providers to be able to access all that information immediately. So that integration is extremely important. I think the systems are moving in the direction that that will be achieved. We're not there yet, but I think we have the capacity within the current system to get there.
Good, thank you.
Good morning.
Morning.
I believe the ability to successfully implement this record in a level 1 facility will be very informative and telling. And I think until we've reached this point, we certainly support the Secretary and the Undersecretary of Health's vision for a new electronic health record.
Great, thank you.
Thank you. The system as it exists now is currently not meeting our needs. Having said that, there have been marked improvements in specific areas. One area for our facility is the ability for our pharmacy technicians to be able to refill prescriptions in MMR, which takes some of that responsibility off of our pharmacists. In addition to that, in lab, they've been able to identify a number of efficiencies as well. So manifests are better, as is the chain of custody. The lab add-on process is much more efficient. It's easier to see who placed a point of care test, and tests that are sent out are available a lot sooner. So while we're not where we need to be, we believe that a VA central office has made the right decision to commit to getting this right at the sites where the system currently exists.
Good, thank you.
Thanks for that question. I think to be fair to the majority of my staff, they would say that the current system is not yet meeting their needs. And they would say there needs to be major changes, not just in terms of incremental gains, but really human-centered design to make this an efficient and usable system for the future of the VA.
And do you think that that will be possible with this system, that we can get there?
I hope so. I think we need to see a change in the slope of improvements in order to think that that would be the case.
Yeah. Thank you very much for your responses. And a couple of you did talk about compatibility just with outside providers. And I represent Virginia's 2nd District, so Hampton Roads, one of the largest veteran populations. and active duty military. I'm also a primary care provider, nurse practitioner. So for me, the frustration with dealing with the VA, there was no compatibility. We pretty much wrote you off if you were a VA patient and our primary care patient. We relied on your word of mouth. Tell us what happened to the VA. What meds are you on over there? So that's wrong. And I can only imagine the errors that stemmed from those conversations. So also being a provider who has sat through 2 different electronic charting implementations at nursing home facilities, I remember the company coming and just sitting with us and really one-on-one, what is right, what is wrong about this EHR. So I think Mr. Kelter, you talked about the process with the staff for configuration changes. What does that look like? Does Oracle sit with the staff? Is there a form they fill out? Do they have written documentation that they write on? What does that process look like?
Sure. Both of those happen. We have Cerner staff at our medical center on a weekly basis. So our staff do have the opportunity to sit elbow to elbow with them and walk through some things, explore their understanding of how the system works and could it be done differently. But the formal request for a change, it's through an electronic ticketing system where they can request a configuration change.
I have other questions, but I'm out of time, so I'll yield back. Thank you.
Representative Franklin.
Thank you, Mr. Chairman, and thank you, panel, for being here today. Appreciate your time, and this to me is the quality of panel and the makeup that we should have had yesterday in a similar hearing we had in Milcon, VA. Dr. Evans, you were there, but the directors weren't, and I'm really glad you all are here today to join us. Yesterday in that hearing that was on the same topic, electronic health records, we were joined by Mr. Cecilia, who's the Executive Vice President of Oracle, and I presume is responsible for the rollout of the system here. And I want to quote a little bit, and I want to get into a little bit on training. And I should apologize up front. I've been bouncing between hearings, so if you've shared any of this, I apologize. Would love to kind of get it all encapsulated here. But on the topic of training, he said, I still struggle with the idea that we have to put people through extensive classroom training to learn to use the system. You don't have to learn to use many IT systems these days. It should be fairly intuitive to be able to pick up a system and use it. That kind of stunned me that he would say that. In the corporate world, I rolled out a few IT systems over the years, and while nothing on a scale of what you all are trying to do, and I'm not trying to underestimate what you're going through, because it's a pretty colossal task. I'd like to know, I'm curious to know, is he out of touch with what you all are experiencing? Because we do know from initial reports of the Grand Staff rollout that the VA acknowledged the Cerner system created unacceptable levels of productivity losses, patient safety risks, and staff burnout. Some of you have alluded to that earlier. I'd love to hear from the staff directors your feedback, what you've received from your staffs on the ease of the system to use and the training they've received in order to complete their tasks. And we don't have a whole lot of time, but if you would kind of be mindful, Mr. Kelter, if you could start, but be mindful of your other 3 cohorts there. I'd love to hear from them too.
Thank you. I would agree that a well-designed, intuitive system should not require a lot of training. This system does require quite a bit for the nuances and the differences and some of the things that might not be so intuitive for staff to learn.
Well, I guess, so a question, real quick follow-up there then. Is it designed properly? If we have some of these steps, I understand there are going to be some specialized things in there, but if some of these steps take as many as 30 to 60 clicks to complete, is that properly designed in your opinion? Should anything require that? That's supposed to be, automation is theoretically supposed to make our lives easier and more accurate, but as we're seeing bear out, that doesn't seem to be the case. Is it a design flaw then, or is it a training issue?
I think some of it is design. I think some of it is configuration. For example, if we could set up the system instead of presenting all of the possible options, some fields are more customizable than others, but if we could limit the options that are immediately presented to the ones most likely to be used, that would make it less likely for somebody to make an error. So maybe my top 5 comes up instead of the 2,000 possible choices.
Dr. Fisher.
Mr. Franklin, as you were mentioning, Mr. Cecilia, I was thinking to myself, was that an aspirational comment about use of the electronic health record? I do not believe the Cerner record exists today is intuitive, and I think the training, according to feedback from my staff as recently as last week, is that training is generally considered to be poor.
I would agree with Dr. Fisher. Staff do not believe that the system is intuitive, nor is it easy to use. In addition to that, training was subpar. And I think, as Dr. Aronson mentioned, it lacks that human-centered design component.
I agree with my VA colleagues. I don't think the system in its current state is one that is intuitive. And I would love to get to a point where it may not be as easy as my 4-year-old trying to work my iPhone, which she does quite well, but to see a system where we can have a trainee, we have a lot of medical trainees rotate through VA medical centers, and we can't spend a week of their training teaching them how to use the electronic medical record. They need to be in the operating room. They need to be seeing patients and able to intuitively do their work.
So during this reset period, is your feedback and input being solicited to help improve the training and the rollout? Or is it just being sort of an edict handed down from on high?
Our input is being solicited. I think the reset is really just starting, and so the feedback for the training in particular, I would have to defer to Dr. Evans for the plans for that.
Well, I see my time is up, Mr. Chairman.
Representative Van Norton.
Thank you, Mr. Chairman. I just want to go back to something earlier. There's a question that was asked to you, Dr. Fisher, by my colleague, Mr. Rosendale. He asked you if the VA, or excuse me, that Oracle and everybody's still getting paid even though they're not doing anything. And you said, I think that's fair. I looked up fair, and it says, open to legitimate pursuit, attack, or ridicule. That's what's going down now. That is a yes or no question, sir. Is Oracle still getting paid? And we're pushing $49.8 billion over the life cycle of this. Is Oracle getting paid? Yes or no? I don't want any other words, one or the other, sir.
I apologize, it's not a yes or no question in my opinion.
Okay, then
I don't know what.
No, we're not doing that.
Fine.
I'm not doing that.
Understood.
That is a yes or no question, and you know it. This is absurd. I live in a really small town, and we have an independent, nonprofit hospital that is doing everything that apparently you can't, to the tune of $49.8 billion over a life cycle. Unacceptable. Just not. I want it to be clear that you're not doing anything new or novel. How many hospitals, Dr. Evans, are in the United States of America? How about a guess?
I don't know the answer to that.
Okay, yeah.
Several
So
thousand.
check me out. The next biggest town up the river from me, you can call 911 from a farm in the middle of rural Wisconsin, and before you're at the emergency room, they have the appropriate bed for you, waiting for you in rural Wisconsin. And I'm beside myself. Dr. Evans, where do you get your health care?
That's a good question. My wife reminds me regularly that I need to get a primary care provider.
Okay, great. Where do you get your health care, man? This is not a funny ha-ha thing. Where?
I mean,
is it the VA?
I don't get the health care at the VA.
Mr. Keltner, where do you get your health care? Is it the VA?
It is.
Okay, where?
Walla Walla, Washington.
Okay, right on. How about you, Mr. Fisher?
In the community.
Okay. Ms. Nelson?
In the community.
Doctor?
I'm not a veteran, so not eligible for VA
Okay, so we
care.
got one person. Where'd you serve?
I was active duty Air Force for 10 years and reserve for 20 years.
Right on, excellent. Okay, is your health care good at the VA?
It is.
Okay, so's mine. So I want to make sure you understand this across the board. I get all my health care at the VA. And I'm very proud of my staff. I go to Toma, also to La Crosse to do that. I have to do some community care because it's unavailable. So this ain't on them, it's on you. Mr. Evans, Dr. Evans, that's Dr. DRMD, correct? Not PhD?
Correct.
Okay. You've been on board for quite a while, right?
6 months.
That's your bio. Don't tell me 6 months, man. So in 2018, the VA awarded a sole source contract for this stuff. Did you have any participation in those negotiations at all?
No.
Okay, and then you guys scrubbed the program. You picked up the mantle here as interim director in 2019. And then in 2023, I think it was March, you guys renegotiated, did your reset, right? This is as successful as the Russian reset, by the way. So this was all thrown out and something else was picked up. You were the interim director. Did you have any participation in those negotiations when you renegotiated the stuff with Oracle? Did you? I will remind you that that man swore you in, and you are under the potential threat of, you are under the oath, and if this is not accurate, you will be held liable for perjury. Did you help negotiate these contracts, the new ones?
I need to clarify that question. So first of all, in 2019, I was the interim director of the Federal Electronic Health Record Modernization
Senior
Office.
advisor at the Federal Electric Health Record Modernization Program Office, leading efforts to implement single common federal electronic health record.
Which is a joint office between the VA and the DoD.
All right, dude. Hey, you know what? Director is a director. Did you have any participation in the renegotiation of these billion-dollar contracts that are failing? Yes or no?
Are you talking about in May when we negotiated?
Renegotiate with Oracle? Have you participated between these private for-profit entities? Have you participated in negotiating these contracts?
We awarded, so the contract was awarded in 2018, as you
I know.
mentioned. It was a 5-year contract.
Yep.
With a 5-year option period.
May 16, 2023, did you participate in these negotiations?
So I was not actively participating in negotiations, but as the senior leader, I was involved with the decisions on where that ended.
All right. I want to talk to you later.
Okay.
And I want dates and times, because we're talking $49.8 billion, and it's working worse than before. That is unacceptable. And I suggest, Mr. Evans, Dr. Evans, you listen to your wife, get a primary care physician, see if we can get a waiver so you're seen at the VA. You don't have a dog in this fight. That's wrong. With that, sir, I'm sorry for going over time.
Representative Mays.
Thank you, Mr. Chairman. I want to thank our witnesses for being here with us this afternoon and answering our questions. I'm going to dive right in. Dr. Evans, I'll start with you. The VA serves our veterans who understand and have lived their lives within the context of a chain of command and following orders. Why does the VA not think they need to follow suit in terms of implementing a standardization? The second or upcoming phase of the reset seems to be the place where the current live sites will see the most benefit. Can you give us an update on the work expected in this next phase and how you're working with both site and VIS and leadership to deliver improvements to the system?
On your first question, I think there's recognition within the healthcare system about the importance of standardization in order to successfully implement the EHR. I think that recognition is at the leadership level. I was heartened. I was at a field informatics conference a few months ago where the informatics leaders, frankly, from the 5 sites stood up and talked about how much they understood the importance of standardization. So I think there's an understanding that we need to do that. Doing it is the challenge that we're now.
So when will the VA start making standardization decisions?
We're currently making those.
Mm-hmm. And how is the VA going to shift this culture of standardization across the board? I mean, the DoD has done it, but the DoD has a very cohesive, there's a chain of command, it's unilateral across the board. The VA seems to, there's a lot of, it seems like infighting or people that want to do their own thing and not go along with a national standard. How long do you think it'll take the VA to accept this shift and a change in the way you look at it?
Yeah, I bring it up a notch. I think what people want is the electronic health record to work for them. Mm-hmm. And people don't resist standardization if the way we're standardizing makes sense, is intuitive, and works as part of clinical care delivery. And so in part—
Does the VA, have culpability? Is the VA responsible for where we are today? Yes or no?
I think, Look, we have...
Does the VA accept any responsibility with where we are today with the implementation of this?
Of course, we're part of this, right? We are implementing the record, and so the decisions that we've made to date are done as part of a partnership in moving forward, right? This is where, I mentioned earlier, one of the things that we need to do, and we know we need to do, is build the expertise of the VA workforce. A change does not happen to an organization leads through change.
And moving from 130 systems and processes to one, governance will play a central part in that. That's not an easy feat. The VA must take a more aggressive role in change management for the good of the 171 VA MCs within it and the 9 million veterans enrolled in the system. So what kind of governance mechanisms will you rely on to get to a standard product and processes and then be able to maintain it?
Yeah, in part, and related to your earlier question about what are we doing at this phase of the reset, this is actually part of the work that we're doing. We've identified an initial set of items that we need to fix, and we are working through that list. And in part, that is not just about fixing the items, but it is about solidifying the governance structure, about how we will efficiently make those decisions about the changes we need to make and the standardization. We call it the rapid EHR baseline improvement. We use that word rapid because we're looking to not just establish strong governance around decision-making, but also efficient governance.
I would love to see efficiency at the VA. I hope you make good on that promise. Understanding within the enterprise system all of that and the challenges ahead in terms of a national standard and adhering to a standard for the betterment of the VA, will each of you commit to a national standard so we can move this thing forward and get it done with? Yes or no? Dr. Evans?
Yes.
Mr. Kelter?
Yes.
Dr. Fisher?
Yes.
Ms. Nelson Brooks?
Yes. I'd like to qualify that it needs to be a standard we can validate that we can meet the needs of our veterans.
Yes or no question. This isn't an argument. We have 9 million veterans enrolled in this system, and I'm trying to have a constructive conversation about how we move forward and not be an asshole when I'm in this room, because it's just too important to members of my family and to millions of vets across the country who are enrolled. Either you can be a team player or not, and if you're not going to be, I'd find a new job. Thank you, Mr. Chairman, and I yield back.
Mr. Luttrell.
Dr. Evans, on the past 5 years, what's the roundabout dollar amount that we've spent on this program to date?
We spend money in support of...
Just give me a good round number. I don't have that much time.
A good round number would be on the EHR itself, we've expended $3.5 billion, on infrastructure, $2.1 billion.
Okay, so roughly around $5 billion for 5 hospitals. Do the 5 hospitals communicate well, or are they siloed?
We're able to see the record for the entire 5 hospitals that are
So if you
live.
needed to talk to Ms. Nelson, you could do that
I could.
effectively.
I could.
And there's 171 hospitals across the continental United States. And so far, it's cost us $5 billion for 4 hospitals, 5 of which, the one in Chicago that's not stood up yet. Is that correct?
That's correct, North Chicago.
So $5 billion, and we've got another 166 to go. Give me a good round number on how much that's going to cost us.
I don't know.
Remember, I have to answer to
I understand.
my base back home. If I'm going to tell them I have to spend $1 billion on every single hospital.
Yeah. So I think the first thing is to understand that of that $5 billion, a good portion of that investment has also been made in the infrastructure improvements in many sites that we're preparing to go live, and we won't lose that investment.
Which we've absolutely failed on if we're in a hard reset. And the young ladies at the end of the table just said that it's not working well enough for their employees to maneuver through it.
Right, but
So
these are
if we are in a hard reset, which in your statement you said, we do not have a firm timeline for completion of this project. And as a military man myself, I do appreciate if we're going to run an operation, the one thing that we do know is when it's going to happen. So I find it challenging to understand how you're going to complete this journey that you're on without any given time frame whatsoever, because next time you sit in front of us and ask for a couple of $1 billion, we're more apt to say no.
Yeah, so I think 2 things. We are making an investment. I mean, the investment in infrastructure is providing value now. So that's improved Wi-Fi networks, the network upgrades that were necessary to support the system benefit the delivery of care with the current record, telehealth care, telehealth delivery at those sites. One of the things we have promised is that as we come out of reset, we will do two things. We will publish a schedule and a life cycle cost estimate. And that's part of the analysis we're doing right now. We feel an urgency to get restarted. We do feel an urgency to get restarted. We can't restart until we see sufficient improvement at the live sites, until we have learned from.
Is it too deep of a hole for me to ask what that looks like to you?
What improvement looks like?
Yeah.
Rock solid technical performance of the system. Improved user satisfaction as measured by the voices of our clinicians.
What does that number look like, Ms. Nelson? Is that a 95%? Is that 100%? I'm curious how he's going to know how to activate. What number is going to come from the hospitals that you operate, any one of you, in order for our leadership to move forward?
Specifically looking at user satisfaction?
Yes, ma'am. We can start with that.
So I would say that, if we take into account the survey that we did in April, where 86% of our staff did not agree with deployment.
86% did not?
86% of staff did not agree with future deployment of the record in its current state. I would say that at a minimum, we would have to get to more than 50% of our staff would recommend use of the system.
Seems like a pretty deep hole, Mr. Evans.
That's why we're in a reset.
With no timeline.
I wouldn't say that we have no timeline. I think we have had, in this program, and again, I
understand this is probably frustrating to you, but you got positioned in this little spot, so I'm going to have to hold you accountable because you're the boss.
I understand. And, when I transitioned to this program 6 months ago, it was as the leader, it was very clear to me that we had to take the time to get things right. And it's been mentioned, we took earlier in the program a strategic pause. And we spent a lot of time thinking about the strategy, but one of the challenges there was we put a hard stop on that. We said, we're going to start deployment activity again, right? And so we didn't take the time that we needed to get it right. And frankly, what I've heard from this committee and the Technology Modernization Subcommittee very consistently has been, VA, take the time to get this right. Not VA, take the time to get this right and take your time. No, feel an urgency to get it right. I feel an urgency because of the folks to my left and the frontline providers that they represent and the veterans that they serve. We feel that urgency, but we're taking the time. And we're very specifically saying there is not a hard end date to the reset because we need to get this right. But I think we can't be in reset forever, right? This is an investment we're making. And so we are, again, measuring our improvement. We're going to be looking at how things are improving over the coming months. We're going to learn from a go-live at the North Chicago facility at the Level Federal Healthcare Center in the spring of 2024. That will be the first Level 1 facility where we go live. We will benefit from partnership from the DoD in that. And then as we move towards the early summer next year, I think we should be having some very significant discussions about restart. Now, restart doesn't mean a go-live right away. It means that we're starting to do the deployment preparations for other sites while continuing to improve. We are on a journey where we will need to be continuing to improve this record in perpetuity. No record is static.
Thank you.
Thank you.
I yield back, sir.
Mr. Sisamonke, you're recognized.
Thank you, Mr. Chair. I would like to allow my colleague, Ms. McMorris-Rogers, to go before me, sir, if that's okay.
That is perfect because she is the one that probably has been affected the most by this.
Absolutely. Please.
McMorris-Rogers, you're recognized.
Thank you. Thank the gentleman for yielding. Thank you, Mr. Chairman and Ranking Member, for bringing us all together here today, holding this hearing, and giving me an opportunity to address the committee. The Oracle Cerner electronic health record system has been a complete failure. It's created more problems than it's solved. And from the beginning, veterans in Eastern Washington have been sounding the alarm about the issues with the EHR. We've had prescription errors, dropped appointments, lost referrals, costly mistakes that have directly harmed nearly 150 veterans, 150 men and women who risked their lives for our country, harmed by the very agency who promised to care for them upon their return. Irresponsible doesn't even begin to describe it. And to make matters worse, this broken system has completely demoralized employees who were not adequately trained on the new system. Providers and support staff have struggled to overcome the software glitches and the constant outages. They've been hung out to dry, trying to help frustrated veterans navigate a system that they themselves are burdened by. And for too many, it's become too much. The devastating amount of employees that are quitting because they're exhausted and just can't take it anymore. This is making bad staff shortages worse, creating longer wait times and making it even more difficult for veterans to get the care that they need. This system has become such a problem that is consuming the budgets of our local VA facilities, causing them to operate at a loss. For months, we've heard rumors of reducing staff and services to make the numbers work, which is not the solution that should even be on the table. While Secretary Madonna committed to me that this won't happen, I need to reiterate that any cuts would be unacceptable. We've already invested billions of dollars into what was once a great idea that has unfortunately failed to achieve its sole purpose, to improve health care for veterans in the United States. We've given the VA and the Oracle Cerner every possible opportunity for improvement. But the problems with the system are endless. Veterans in Eastern Washington have had enough, and they're tired of being the guinea pigs in this failed experiment. They've pleaded for it to stop, but their concerns and mine have been dismissed at every turn. The VA's lack of transparency has led to a devastating breakdown in trust among veterans, and it must change. We all agree that we have to get this right for our nation's heroes. I believe it's time to pull the plug on this deeply broken system, and let's go back to one that's going to work. But until then, I am committed to helping get this working as much as we can for our veterans who have no other choice. So I wanted to ask just a couple of veteran questions. Dr. Fisher and Dr. Arrowsman, I understand Mann Grandstaff in Columbus are the only VA medical centers using the Oracle Cerner's oncology modular right now, and it's created serious problems. Can you explain some of the multi-drug chemotherapy orders work and where the problem is, starting with you, Dr. Fisher?
Well, we have a very experienced medical oncologist in Spokane, and he is very reluctant to utilize multi-agent chemotherapy currently. He would like to test those power plans in production to make absolutely sure that there are no medication errors, because they're lethal with the use of these very, very significant medications.
Thank you.
Sure.
Thank you for that question. The power plants have been a significant challenge in Columbus as well. We've actually dedicated a half-time oncologist and a half-time pharmacist. They have their full-time employees, but half of their time is spent essentially editing, correcting, and validating power plans. The caveat that I mentioned with Ms. Mace's question earlier was actually standardization is wonderful and it's important, and I fully believe in it, but we don't want to standardize to the point where the only anti-nausea med on a power plan is one you don't have in stock in your city. We don't want to standardize to the point when there's supply chain shortages, we can't meet the care of the veteran because we don't have that particular bag of saline or the diluent that's necessary. So that's why it takes a long time to try to get this right, and we want to make sure we're doing that.
Thank you. Dr. Evans, I'd like to ask how long you've known about the oncology prescription problem with the Cerner software and what you're doing about it.
I visited the Columbus facility probably within 2 weeks of my starting in this position, approximately 6 months ago. And this was a point of significant, we spent an entire hour on the oncology discussion. We are spending a lot of time working on the power plans, as has been mentioned, and also essentially empowering us as an organization to edit our power plans and determine what those look like. That's part of this workforce development I was talking about earlier, about bringing the expertise into VA so that we can configure the ordering, and make sure we deliver that to Oracle to put into the system in a way that best meets the needs of veterans.
Thank you. This is just one example, but it underscores how grave the situation is. And to all who work at the VA, at the medical centers I represent in Spokane and Walla Walla, I just want to say thank you for trying to make the best of what's been an extremely difficult situation for our veterans. I yield back.
Mr. Zismani.
Thank you, Chairman Boss, and thank you to the witnesses for being here today, for providing your testimonies as we conduct oversight over the effort to replace the VA's electronic health record. Now, for years, Cerner has been working to develop this software for our veterans in the VA facilities, but this system has been plagued with issues. I think we've been discussing a lot of them here today. Issues with the electronic health record crashing and freezing and requiring excessive steps to complete routine functions, resulting in software not being user-friendly, difficulty in veterans ordering prescription refills, and other problems that 5 VA medical facilities with the system are now facing. Now, I represent Arizona's 6th congressional district, and veterans in my district go to the Tucson VA Medical Center, which luckily is not one of these 5 facilities mentioned. Mr. Evans, Dr. Evans, the VA gave the committee a timeline showing what steps you intend to take during the reset period that you've talked about to improve the Oracle Cerner electronic health record system. One of the steps is to, and I quote, initiate team efforts at one of the 5 live sites to address and identify issues, end quote. In other words, put boots on the ground at one of the medical centers to figure out what they really need. So which facility has been picked for that, and why and how is it going to represent the other 4 facilities?
We hosted several weeks ago a planning event in Kansas City to plan the work. The specifics on that is some of the configuration changes that we need to make don't require us to be on site and sort of in the operations. We don't want to interfere with the delivery of patient care in fixing the EHR. But there are times where being on site, observing exactly how the system is working is going to help us make the right decisions. All 5 sites are involved with all of the discussion, and as I mentioned before, the national programs, since we need to not just configure the record for the benefit.
I'm sorry, I have limited time here. So what you're saying is you haven't picked one yet?
We're going to work with all 5 sites.
So you changed
Not
course?
just
You
one.
changed, so the plan to pick one and tackle that, after what you just mentioned, you decided to go after all 5 at the same time?
We're going to go to where we need to go in order to fix the problem, yes.
Okay, so you're not, so you changed plans then, so you're not choosing one anymore on that. And then the question for, I guess, the center leaders here, if now that your facility is not going to be chosen individually, because that was going to be one of my questions, once that facility is chosen, what happens there? But since now the plan changed apparently, and you're tackling where it needs it, and quite frankly, seems to be that all 5 need it. The question is for all of you, when your facility is chosen, which has been declared now that everyone is chosen, how are you going to make sure that these needs are addressed? How do you go into there and actually look at the needs and then make sure that they're addressed? And I don't have a lot of time, so I would appreciate a direct, concise answer.
So I think there would be different capabilities that would be appropriate to test at each facility. So certain capabilities exist at different facilities that don't exist at all of them. So that approach makes sense from that perspective. And then how do we make sure they work? What can be tested without actually making the configuration changes may be limited. I'm not sure what can be done in a test environment versus in the production environment at this point.
Mr. Fisher?
Ask the end user. I have 1,400 experts that function every day to deliver healthcare or support healthcare. We'll know we're making traction by simply asking the end user, is the product better? Do you like it? Is it helpful? These are simple assessments, and we'll need to do those type of surveys repeatedly.
Is that being done now?
It is, but it's
Are you seeing results now?
not yet. And these
So
type of
something's
surveys...
not working here. We're missing something here. It's just, that sounds to me, Dr. Evans, like a meeting to plan for the meeting that we're going to plan to do something. It just, I'm not understanding maybe this correctly. It just seems that we're not addressing the issue. You're not addressing the issue directly here. You have a plan that seemed like a plan that might work of choosing a facility, digging deep into that. Now you're going across all 5. And as we're going across here, whatever plans that are being shared with us here, they sound good, but they may not or may be working. We don't know that. So the timeline here is what worries me. You're way behind.
Yeah, if I may, the timeline that we shared with the committee, we initially thought we would have our initial kickoff meeting at one of the sites. We chose to have that in Kansas City so we didn't disrupt operations. And then we've identified where do we need to go. You heard that 2 of our facilities have oncology services, 2 do not. And so where we need to go to make changes if we need boots on the ground will be determined on the impact on that site, whether they can host us, and what services are delivered there. But we're all in this together. We are building a single, and we are improving a single electronic health record.
I've got more to say, but I'm out of time. So thank you. Yield back.
Mr. Crane, you're recognized.
Thank you, Mr. Chairman. Thank you all for coming today. I understand centralization and standardization of a system this large nationwide is a monumental task. I also understand the benefit this effort could create for staff and patients alike. However, it obviously sounds as if right now it's been an absolute failure. So I want to start with you, Doc, on the end. Knowing that you and the rest of Americans continue to pay for this debacle, Doc, what level of confidence do you have in partnerships, the current partnerships and leadership engaged in this effort? I'm really asking clearly about your level of confidence moving forward.
Thanks for the question. Obviously, it's a hugely challenging process and a daunting task. I think I've been very pleased to see Dr. Evans' leadership and understanding of the issues and commitment to stop and take the time we need to get this right and not push forward when things are not safe or when things could be improved.
So what's your level of confidence? That was a question I asked you.
In what? In an individual, in a process?
Yeah, in the partnerships that we have, the company that the corporation company that you're working with, and in the leadership that you have.
I think I have a moderate level of confidence.
Okay, moderate. Ms. Nelson Brooks, what about you, ma'am?
In terms of my level of confidence in or leadership's ability or their commitment to getting this right, I would say I have a high level of confidence. I believe that Dr. Evans, Dr. Elnahal, Secretary McDonough are committed to fixing the system as it exists currently. In terms of Cerner's ability to meet our needs, I would say my level of confidence is a lot lower. On a scale of 1 to 10, I would give it a 5.
Ms. Nelson Brooks, do you think that we should scrap what we're doing and go back to the old system based on what you are observing and the percentage of your staff that seems to be very disappointed with where things are?
I agree that our staff are very disappointed with the way things have gone. I do not believe that we're at the point currently where we need to pull the plug entirely.
What's the biggest effect that you've seen on patients with the rollout of this new system?
The biggest effect for our facility has been our increase in wait times. Pre-Cerner, we were able to see new patients in for primary care appointments in less than 30 days. Currently, our new patient wait times in Eugene, one of our largest facilities, is approaching 80 days. And for Roseburg, our other location, it's over 80 days. It's closer to 85 days for in-person care. The caveat that I will mention there, however, is that if patients are willing and able to be seen by telehealth, we do have the ability to get them in within 7 days.
Doc Fisher, what's your level of confidence?
I would agree with Dr. Ahrensman. I would say it's moderate.
Moderate? What would you like to see going forward, Doc?
Improvements in the functionality of the system, less degradations, more user satisfaction, things you would anticipate you would see with a successful electronic health record.
Are you saying that most of your disappointment is in the partner that we've chosen here?
Hard for me to say, sir. I'm not an expert in IT. All I know is that our employees are fatigued, tired, stressed. They feel like they're the individual that stands between the health record and making our patients safe, and they have been largely successful, but at a cost.
Mr. Kelter, same question for you.
I would say between the commitment of our leadership from the secretary on down to the recently renegotiated contract and the fact that we have a one-year contract options instead of a 5-year contract option, and the current reset period, I think our chances are better now than they have been in the past.
Doc Evans, did I hear you say you've been doing this role now for 6 months?
That's correct.
Are you ahead or behind of where you thought you would be coming into this at the 6-month mark?
I would like to have been further. So I don't think we're, I think the changes have been slow and incremental. They need to accelerate. Anytime you are starting the reset and sort of retooling for moving forward, it's going to take a little time to get the engine running and to build the momentum that we need to build. So am I proud of the organization for listening to this committee, for making the right decision on behalf of veterans and the staff that you know or you've heard are represented by the folks to my left? Absolutely. We made the right choice to reset. But we still have a lot of work to do, and we are committed to doing it.
Thank you, Mr. Chairman. I yield back my time.
Thank you. At this time, I would like to recognize Ms. Shafullis McCormick for the closing marks of the ranking member.
Thank you, Mr. Chairman. I thought we had a productive discussion today. Dr. Evans and his team have their work cut out for them. I look forward to working with you all to make sure that veterans and VA staff get the technology they need to support the world-class care our veterans deserve. I'd like to thank the chairman again for his and his staff's collaboration and effort on the House's version of the EHR reset. It's even more evident to me now how necessary this legislation is. We need to put the VA on a course where they can be successful. Veterans and staff have endured enough. Thank you, Mr. Chairman. I yield back.
Thank you. And I want to thank everybody for being here today. I want to thank the witnesses for joining us, especially in the medical center directors who traveled here. The VA EHR is a bipartisan mess, and it calls for bipartisan solutions. We can't stand by anymore and hope VA and Oracle Cerner figure it out. That approach already produced 2 pauses and failed to solve the problem. We have to insist on the results and accountability. I appreciate the ranking member Takano and Rosendale, Chairman Rosendale, and ranking member Shafullis McCormick for standing shoulder to shoulder with me to do that. Now, I ask unanimous consent that all members shall have 5 legislative days in which to revise and extend their remarks and include any extenuous material. Hearing no objection, so ordered. This hearing is now adjourned.